How do you perform a head-to-toe assessment on a new patient?
When performing a head-to-toe assessment on a new patient, my primary goal is to establish a comprehensive baseline of their physical and mental health. This systematic process ensures that no critical information is missed and allows me to identify potential problems early. I always begin by introducing myself, explaining the purpose of the assessment, and ensuring the patient's privacy and comfort. This builds trust and encourages cooperation. I start the physical examination at the patient's head, checking their neurological status. I assess their level of consciousness, orientation, and pupillary response. I then move down to the neck and chest, listening to their heart and lungs for any abnormal sounds. I check their respiratory rate and effort to ensure they are breathing comfortably. Next, I examine the abdomen, checking for bowel sounds, distension, or tenderness. This step is crucial for identifying any gastrointestinal issues. After the abdomen, I assess the patient's extremities. I check their peripheral pulses, skin color, temperature, and capillary refill time to evaluate circulation. I also test their motor strength and sensation in both their arms and legs. I conclude the physical assessment by examining the patient's skin, paying close attention to any signs of breakdown, bruising, or rashes, especially over bony prominences. Throughout the entire process, I'm also observing their overall appearance, hygiene, and emotional state. Every observation is meticulously documented in the patient's chart. This thorough and methodical approach allows me to create a detailed, accurate record of the patient's condition, which is essential for developing a safe and effective care plan.
What are the 5 rights of medication administration, and how do you ensure compliance?
The 5 rights of medication administration are a critical safety protocol used to prevent medication errors and ensure patient safety. They serve as a mental checklist for every single medication I administer. The 5 rights are the right patient, the right drug, the right dose, the right route, and the right time. To ensure compliance with each of these rights, I follow a systematic process every time I prepare and administer medication. First, to confirm the right patient, I always use at least 2 patient identifiers, such as their name and date of birth, and cross-reference them with a medication administration record mark. Before preparing a medication, I verify the right drug and right dose by carefully reading the prescription order and the medication label. I check the expiration date and ensure the medication's name and dosage match the physician's order exactly. I then calculate the dose myself if necessary, and have another nurse double-check it for high-risk medications. For the right route and right time, I verify the prescribed method of administration and the schedule against the march. For example, if the order is for an oral medication to be given twice daily, I ensure I give it at the correct scheduled times and that the patient takes it by mouth. I never assume, I always clarify if there is any ambiguity. I also take a final moment before administering the medication to reconfirm all 5 rights one last time. This rigorous process of triple checking, at the time of gathering the medication, at the time of preparation, and at the patient's bedside, is how I ensure my practice is consistently safe and compliant with professional standards, minimizing any risk of error.
Describe your approach to managing a patient with sepsis.
When managing a patient with sepsis, my approach is guided by the principle of early recognition and rapid intervention, as this is critical to improving outcomes. My first priority is a prompt and thorough assessment to identify the signs of sepsis, which can be subtle. This includes assessing for high fever or hypothermia, elevated heart rate, increased respiratory rate, and any signs of altered mental status. I also look at laboratory results for indicators like elevated white blood cell count and lactate levels. Once sepsis is suspected, my immediate action is to follow the sepsis care bundle, a set of evidence-based interventions that must be initiated within the first hour. The core components of this bundle include obtaining a blood culture before administering broad-spectrum antibiotics, measuring the patient's lactate level, and administering intravenous fluids to combat hypovolemia. Throughout this process, I communicate continuously with a medical team, providing them with real-time updates on the patient's condition and any changes in vital signs. Following the initial interventions, I maintain close, continuous monitoring of the patient. This involves frequent checks of their vital signs, urinary output, and level of consciousness to assess their response to treatment. I also ensure that the patient is receiving the correct medication and that any side effects are managed promptly. My documentation is meticulous, noting every observation, intervention, and communication with the medical team. This comprehensive approach, rooted in early identification and swift, coordinated action, is essential for effectively managing a patient with sepsis and preventing further deterioration.
How do you confirm nasogastric tube placement before initiating feeding?
Confirming nasogastric NG tube placement is a critical safety step to prevent life-threatening complications like aspiration pneumonia. My approach involves a multi-step verification process to ensure the tube is correctly positioned in the stomach before I initiate feeding or administer medication. The first and most reliable method is to verify the tube's position with an X-ray. This is the gold standard for initial placement confirmation, especially when the tube is first inserted. Once the X-ray has confirmed proper placement, I use a combination of bedside tests for ongoing verification. The primary bedside method I use is pH testing. I aspirate a small amount of fluid from the tube and test its pH using a special strip. A pH of 5.5 or less is a strong indicator that the tube is in the stomach. I also perform a visual check of the aspirate. Gastric contents are typically grassy green, clear, or brown. If I aspirate fluid with a pH greater than 5.5, or if the fluid appears milky or yellowish, it could indicate placement in the lungs or intestines, and I would not proceed. In addition to pH testing, I also rely on external measurements. I check that the external marking on the tube at the nostril remains the same as when it was first placed, which helps confirm the tube has not migrated. I also listen for the sound of air entering the stomach, auscultation, while injecting a small amount of air through the tube with a syringe. While this method is not as reliable as pH testing or X-ray, it is a quick adjunct that provides additional assurance. Following all these steps, I meticulously document my findings and the method used for confirmation in the patient's record. This diligent process is essential for providing safe, high-quality care.
What steps do you take when a patient shows signs of hypoglycemia?
Hypoglycemia, or low blood sugar, is a serious and potentially life-threatening condition that requires immediate and decisive action. When a patient shows signs of hypoglycemia, such as shakiness, confusion, sweating, or a rapid heartbeat, my first step is a rapid assessment to confirm my suspicion. If the patient is conscious and able to swallow, my immediate priority is to administer a fast-acting carbohydrate. This could be in the form of glucose tablets, a sugary drink like fruit juice, or hard candies. The goal is to raise their blood glucose level quickly. I will stay with the patient, rechecking their blood sugar every 15 minutes to ensure it is rising. If the patient is unconscious or unable to swallow, I would never attempt to give them anything by mouth due to the risk of aspiration. In this case, my next step is to administer an emergency treatment, such as an injection of glucagon. While one nurse prepares the injection, another would immediately alert the medical team and activate the emergency response system. This quick and coordinated action is vital for patient safety. Following the initial treatment, I will provide a longer-acting carbohydrate, such as a sandwich or crackers with peanut butter, once the patient is alert and able to eat. This helps to stabilize their blood sugar and prevent it from dropping again. Throughout the entire process, I document all my observations, the interventions I performed, and the patient's response. I also ensure that the patient's physician and family are informed. This systematic approach, combining rapid assessment, immediate intervention, and meticulous documentation, ensures the patient receives timely and effective care to prevent further deterioration.
How do you respond to a sudden drop in blood pressure post-surgery?
A sudden drop in a patient's blood pressure post-surgery is a critical event that demands an immediate, systematic response. My approach is rooted in the principles of prompt assessment, rapid intervention, and continuous monitoring to stabilize the patient. My first priority is always to get a full set of vital signs and perform a focused assessment to identify the likely cause of the hypotension. This includes checking the patient's heart rate, respiratory rate, and oxygen saturation, and assessing their level of consciousness, skin color, and warmth. I will also quickly check surgical dressings for any signs of hemorrhage. Once I have a clear picture of the patient's status, I immediately initiate interventions. I elevate the patient's legs to improve blood flow to vital organs and ensure their airway is clear and breathing is uncompromised. I then notify the surgical team or a rapid response team and provide them with a clear, concise SBAR, situation, background, assessment, recommendation report. This ensures they have all the necessary information to act quickly. In collaboration with a medical team, I will likely administer an intravenous fluid bolus to increase blood volume and pressure. I also prepare to give vasopressor medications if they are ordered. Throughout this entire process, I maintain continuous monitoring of the patient's vital signs and level of consciousness, carefully documenting every intervention and the patient's response to it. This vigilant observation allows me to quickly adjust my care as needed. This methodical and collaborative approach to a sudden drop in blood pressure ensures that I can address the patient's critical needs effectively and prevent further deterioration.
What is your protocol for wound care in diabetic patients?
My protocol for wound care in diabetic patients is a comprehensive, evidence-based approach that prioritizes early intervention, thorough assessment, and meticulous management. I understand that diabetic wounds are complex due to neuropathy, poor circulation, and a compromised immune system, making them susceptible to infection and delayed healing. The first step is a holistic assessment of both the patient and the wound itself. I check the patient's blood glucose levels to ensure they are well controlled, as this is fundamental to healing. I also assess their overall health, including their nutritional status and a detailed history of the wound. For the wound itself, I perform a full assessment, noting its size, depth, location, and the condition of the surrounding skin. I also check for signs of infection, such as redness, swelling, warmth, and purulent drainage. My next step is to clean and debride the wound. I use a sterile technique to irrigate the wound, removing any debris or dead tissue. Debridement is crucial for promoting healthy tissue growth. Following debridement, I select a dressing that is appropriate for the wound's specific characteristics, whether it is an alginate for a heavily draining wound or a hydrocolloid for a less severe one. I also work to offload pressure from the wound site, as continuous pressure can impede healing. Finally, I provide comprehensive patient education. I teach the patient and their family about proper foot care, the importance of blood glucose management, and how to recognize the signs of infection. I also schedule regular follow-up appointments to monitor the wound's progress and adjust the care plan as needed. This holistic and proactive approach is essential to ensuring the best possible outcome for my diabetic patients.
How do you manage a patient with a high fall risk?
Managing a patient with a high fall risk requires a proactive and multifaceted approach focused on prevention, patient education, and a supportive environment. My strategy is centered around a comprehensive fall risk assessment upon admission, followed by the immediate implementation of a personalized prevention plan. The first step is a thorough fall risk assessment. I use a validated tool like the Morse Fall Scale to evaluate factors such as age, history of falls, mobility issues, medication use, and cognitive status. Based on a score, I categorize the patient's risk level and develop an individualized care plan. For a high-risk patient, this plan would include immediate interventions to create a safer environment. This means ensuring the call bell is always within reach, placing the bed in the lowest position, and ensuring the room is well lit and free of clutter. I also apply a fall risk bracelet and place a clear visual sign on the door to alert all staff members to the patient's condition. Patient and family education is also a crucial part of my approach. I take the time to explain the importance of using the call bell and the risks associated with getting out of bed or a chair without assistance. I encourage family members to support the care plan and teach them about what they can do to help. I also coordinate with other healthcare professionals, such as physical therapists, to initiate mobility and gait training, and with pharmacists to review medications that may increase fall risk. By combining a systematic risk assessment with proactive environmental and educational interventions, I can significantly reduce the likelihood of a fall and ensure the patient's safety throughout their stay.
What actions do you take during a transfusion reaction?
A transfusion reaction is a medical emergency that requires immediate and precise action. My protocol is centered on stopping the transfusion, assessing the patient, and notifying the medical team without delay. The moment I suspect a reaction, my very first step is to immediately stop the transfusion. I clamp the blood bag tubing and, crucially, keep the foreline open by flushing it with a new bag of normal saline to maintain venous access. After stopping the transfusion, my immediate focus shifts to assessing the patient's vital signs and symptoms. I will quickly check their blood pressure, heart rate, respiratory rate, and oxygen saturation. I also ask the patient if they are experiencing symptoms such as fever, chills, back pain, or shortness of breath. This rapid assessment is critical to determining the severity of the reaction. While maintaining close observation, I notify the physician and the blood bank. My communication with the physician is concise and follows the SBAR format, providing the patient's name, the blood product and unit number, and the specific signs and symptoms I have observed. I also gather the empty blood bag, the attached tubing, and a fresh blood and urine sample from the patient. This is done so the blood bank can investigate the cause of the reaction. Throughout this process, I ensure that every action and observation is meticulously documented in the patient's chart. This comprehensive, rapid response is essential for managing the patient's symptoms and preventing further complications.
How do you assess and document pain in nonverbal patients?
Assessing and documenting pain in nonverbal patients is a fundamental skill that requires a systematic and empathetic approach. It relies on my ability to use objective observations and validated assessment tools rather than a patient's self-report. My primary approach is to use a behavioral pain scale, such as the pain assessment in advanced dementia, PAIN-ADS scale, or to the nonverbal pain scale, NVPS. These tools guide my assessment by focusing on 5 key behavioral indicators: breathing patterns, negative vocalizations, facial expressions, body language, and consolability. I will observe the patient's breathing for any signs of shortness of breath or rapid, shallow breaths. I will listen for moaning, groaning, or grunting. I pay close attention to their facial expressions, looking for grimacing, furrowed brows, or tightly closed eyes. My assessment of body language includes observing for restlessness, muscle tension, or guarding of a specific area. Finally, I check if the patient can be comforted or consoled. Based on my observations of these 5 categories, I assign a score, which provides a quantifiable measure of the patient's pain. My documentation is meticulous and includes not just the score, but also a description of my observations. For example, I would write, patient scored 7 on the NVPS, observed for grimacing, moaning, and guarding of the abdomen. Provided a PRN dose of pain medication, and will reassess in 30 minutes. This precise, objective documentation is crucial for communicating the patient's condition to the medical team and ensuring that their pain is effectively managed. This process ensures that I can provide humane and compassionate care even when a patient cannot verbalize their needs.
What is your response to a disconnected chest drain in a post-op patient?
A disconnected chest drain in a post-op patient is a critical emergency requiring immediate and precise action to prevent a tension pneumothorax. My first priority is to prevent air from entering the patient's chest cavity. I'd immediately instruct the patient to exhale and hold their breath while I quickly clamp the chest tube with a sterile clamp as close to the patient's chest wall as possible. This action seals the system and prevents air from being sucked into the pleural space. If a clamp is not immediately available, I would use my hand to pinch the tube and then get a clamp as soon as I can. Once the tube is clamped, my next step is to prepare the system for reconnection. I would quickly swab the ends of both the disconnected tubing and the chest tube with an alcohol wipe to reduce the risk of infection. I would then firmly and securely reconnect the tube to the drainage system. After reconnection, I would unclamp the tube, allowing the drain to resume its function. While taking these immediate steps, I would simultaneously assess the patient for any signs of respiratory distress, such as shortness of breath, increased heart rate, chest pain, or a drop in oxygen saturation. I would also notify the surgeon or the rapid response team immediately, providing a concise SBAR report of the situation. Following the incident, I would meticulously document the time of the event, the actions taken, the patient's response, and the time the physician was notified. This systematic, rapid, and well-documented response is essential to ensure patient safety and prevent further complications.
How do you handle a medication error before it reaches the patient?
An effective quality assurance process is crucial in nursing to prevent medication errors before they can harm a patient. My protocol is to apply the 3 checks of medication administration before a medication ever leaves the preparation area. This systematic approach, combined with the 5 rights of medication administration, is how I ensure patient safety. The first check occurs when I pull the medication from the dispensing system or medication cart. At this point, I verify the medication against the physician's order and the patient's medication administration record, MAR, to confirm that it is the correct drug, the correct dose, and the correct form. The second check is done during the preparation of the medication. As I am drawing up the medication or counting the pills, I cross-reference the label on the vial or bottle with the MAR one more time. This is also where I check the medication's expiration date. The third and final check is my last line of defense before I go to the patient's bedside. I verify the medication and the patient's details with a MAR for a third time, just before I leave the medication preparation area. If any discrepancy is found during any of these checks, I immediately stop the process and reevaluate the order. I would not proceed until I have a clear understanding of the issue, which might require me to contact a physician or a pharmacist for clarification. This triple-check system ensures that any error, whether it is in the order or my own preparation, is caught and corrected before the medication is administered.
What is your process for administering insulin to a newly diagnosed diabetic?
Administering insulin to a newly diagnosed diabetic patient requires a careful and patient-centered approach. My process focuses on 3 key areas: patient education, safety, and a meticulous step-by-step procedure. First, I prioritize patient education. Since they are newly diagnosed, it is crucial to ensure they understand why insulin is necessary, how it works, and what to expect. I explain the difference between the types of insulin they are prescribed, such as rapid-acting or long-acting, and how it will affect their blood sugar. I also teach them how to recognize the signs and symptoms of both high and low blood sugar. This education empowers them and alleviates anxiety. Second, I follow a strict safety protocol to ensure I am administering the correct insulin and dose. After verifying the physician's order and the medication administration record, I perform the 5 rights of medication administration. I confirm the right patient, drug, dose, route, and time. I double-check the insulin type and concentration, as well as the expiration date, as this is a high-alert medication. I also ensure I have the correct syringe or pen device for the specific insulin. Finally, the administration procedure itself is systematic. I perform a blood glucose check to determine the appropriate dose based on their sliding scale. After preparing the injection site, I administer the insulin at the correct angle. I stay with the patient for a short time afterward to ensure they are comfortable and do not have any immediate adverse reactions. I then document every step, including the time of administration, the dose, the blood glucose reading, and the patient's response. This comprehensive approach ensures the patient receives safe and effective care while also preparing them to manage their condition.
How do you manage infection control for a patient with MRSA or C. difficile?
Managing a patient with an infection like MRSA or C. difficile requires a meticulous and proactive approach to infection control to protect both the patient and other individuals. My process is centered on the principle of breaking the chain of infection through strict adherence to isolation precautions and rigorous hygiene practices. The first step is to implement contact precautions. This involves placing the patient in a private room to limit their contact with others. I would place a clear sign on the door indicating the required precautions. Before entering the room, I don a gown and gloves. It's crucial that I remove this personal protective equipment, PPE, before leaving the room to prevent contamination. I also use a dedicated set of equipment for that patient, such as a blood pressure cuff and stethoscope, to avoid carrying pathogens to other patients. A critical aspect of managing these infections is meticulous hand hygiene. For C. difficile, this is particularly important, as alcohol-based hand sanitizer is ineffective against its spores. I would always wash my hands thoroughly with soap and water after removing my gloves and gown and before leaving the patient's room. For MRSA, alcohol-based sanitizer is effective, but soap and water are always the preferred method. I also educate the patient and their family on the importance of hand hygiene. In addition to these measures, I ensure the patient's room is cleaned and disinfected regularly with the appropriate cleaning agents. All contaminated items, such as linens and waste, are handled and disposed of according to hospital protocol. This comprehensive strategy, from isolation to hygiene and environmental cleaning, ensures that I am taking every possible step to prevent the spread of infection and provide safe, high-quality care to all patients.
What is the priority nursing action for a patient experiencing anaphylaxis?
The priority nursing action for a patient experiencing anaphylaxis is the immediate administration of intramuscular epinephrine. Anaphylaxis is a life-threatening medical emergency, and epinephrine is the only medication that can rapidly reverse the severe symptoms, such as airway constriction and cardiovascular collapse. My response is guided by the principle of rapid recognition and swift, decisive intervention to stabilize the patient. After administering the epinephrine, my next steps follow a clear and systematic protocol. I would immediately activate the rapid response team or call a code, as the patient's condition can deteriorate quickly. While waiting for the team to arrive, I would position the patient to optimize their breathing and circulation. This means placing them in a supine position with their legs elevated if they are hypotensive, or sitting them upright if they are having severe difficulty breathing. I would also administer high-flow oxygen via a non-rebreather mask to support their respiratory function and ensure a patent airway. I would then focus on securing or maintaining intravenous for access to administer other supportive medications, such as antihistamines and corticosteroids, and to begin fluid resuscitation to manage shock. I would continue to monitor the patient's vital signs, especially their blood pressure and oxygen saturation, on a continuous basis, and be prepared to perform CPR if they experience cardiac arrest. Throughout this critical event, my communication would be clear and concise, providing a quick SBAR report to the medical team. Finally, I would meticulously document all interventions, the patient's response, and any communications with the medical team. This comprehensive approach ensures that every necessary step is taken to stabilize the patient and prevent further complications.
How do you monitor and document fluid balance in a renal patient?
Monitoring and documenting fluid balance in a renal patient is a critical nursing responsibility that requires meticulous attention to detail to prevent fluid overload or dehydration. My process is a systematic approach that combines accurate measurement, regular assessment, and precise documentation. The primary tool I use for this is the intake and output INO chart. I ensure every single fluid intake is accurately measured and recorded. This includes not just oral fluids but also intravenous for fluids, tube feedings, and any fluid used to flush a catheter or nasogastric tube. I educate the patient and their family on the importance of this, encouraging them to track their own oral intake and notify me of any liquids they have consumed. Simultaneously, I measure and document all fluid output, including urine, vomit, diarrhea, and drainage from wounds or surgical drains. For urine, I use a measuring hat placed over the toilet or a graduated cylinder for accuracy. In addition to the INO chart, I perform regular physical assessments to check for clinical signs of fluid imbalance. I look for signs of fluid overload such as peripheral edema, crackles in the lungs, shortness of breath, or sudden weight gain. Conversely, I also watch for signs of dehydration like dry mucous membranes, decreased skin turgor, a weak pulse, or a drop in blood pressure. The patient's daily weight is also a key indicator, so I ensure it's measured at the same time each day, using the same scale to get a consistent reading. All of these observations, along with the precise INO numbers, are carefully documented in the patient's record, providing a comprehensive picture for the medical team to guide their treatment plan. This diligent approach is essential for preventing complications and ensuring patient safety.
What is your approach to managing a patient with acute respiratory distress?
My approach to managing a patient with acute respiratory distress is a rapid and systematic process focused on three key priorities: ensuring a patent airway, providing immediate oxygen support, and identifying the underlying cause. Acute respiratory distress is a life-threatening condition, and swift, decisive action is critical to prevent respiratory failure. The first and most urgent action is to assess and manage the patient's airway and breathing. I immediately check for any signs of airway obstruction and assess their respiratory rate, depth, and effort. I listen for abnormal sounds like wheezing or crackles, and check their oxygen saturation with a pulse oximeter. My next step is to elevate the head of the bed to a semi-Fowler's position to help ease their breathing. I also administer supplemental oxygen immediately typically via a non-rebreather mask to achieve the highest possible concentration. Once the patient is receiving oxygen, I would quickly notify the medical team or activate a rapid response team. While waiting for them to arrive, I would perform a focused assessment to identify the potential cause of the distress, whether it's related to fluid overload, a pulmonary embolism, or an allergic reaction. I would also establish access for potential medication administration. Throughout this process, I maintain a calm and reassuring presence for the patient, which helps to reduce their anxiety and conserve their energy. I continuously monitor their vital signs, including oxygen saturation, and I am prepared to assist with intubation or other advanced interventions if their condition deteriorates. My documentation is meticulous, recording all observations, interventions, and the patient's response to treatment. This methodical and quick response is essential for effective management and improving patient outcomes in a respiratory emergency.
How do you prepare and administer for antibiotics safely?
Preparing and administering intravenous for antibiotics safely is a critical nursing responsibility that requires a meticulous, multi-step process. My approach is centered on ensuring the 5 rights of medication administration are met at every single stage. First, I review the physician's order and the patient's medication administration record, MAR, to confirm the right patient, right drug, right dose, right route, and right time. I pay special attention to the antibiotic's name, concentration, and the prescribed infusion rate. Before preparing a medication, I check for any patient allergies to the antibiotic and its class, as well as the expiration date of the vial. Once I have verified the order, I perform proper hand hygiene and prepare the antibiotic in a clean, designated area. I reconstitute the medication according to the manufacturer's instructions, using the correct diluent and volume. This is a crucial step that directly impacts the drug's effectiveness and safety. After preparing the 4-bag, I label it with a patient's name, the drug name, the dose, the date, and my initials. This clear labeling is vital for preventing errors. Before administering the antibiotic, I assess the 4-insertion site for any signs of infiltration, redness, or swelling. I then use a sterile technique to connect the 4-tubing to the patient's access site. I program the infusion pump with a correct rate and volume based on the physician's order and double-check all the pump settings. During and after the infusion, I closely monitor the patient for any signs of an adverse reaction, such as a rash or difficulty breathing. Finally, I document the time of administration, the specific antibiotic and dose given, and the patient's response in the electronic health record. This systematic and diligent process ensures the antibiotic is administered safely and effectively.
What do you do when a patient refuses a critical medication?
When a patient refuses a critical medication, my immediate response is to stop and listen. My first priority is to understand the reason behind their refusal, which is a key part of respecting their autonomy and building trust. I would sit down with the patient in a calm and private setting to discuss their concerns. I might ask questions like, "Can you tell me what's on your mind about this medication? Or is there anything you're worried about?" Their refusal might stem from a variety of reasons, such as fear of side effects, a lack of understanding of the medication's purpose, or even a cultural or religious belief. Once I understand their concerns, my next step is to provide clear, concise, and non-judgmental information. I would explain the medication's purpose in simple terms, emphasizing the potential benefits and the risks of not taking it. For example, for a patient refusing a blood pressure medication, I would explain how it helps prevent a stroke or heart attack. I would also address any misconceptions they have and offer to answer any questions they might have. If the patient still refuses after this discussion, I will not force them to take the medication. Instead, I will inform the healthcare team, including the physician and charge nurse, of the patient's refusal and the reasons behind it. I would also document the refusal meticulously in the patient's chart, noting the time, the medication, the patient's stated reason for refusal, and the actions I took to educate them. This ensures that the entire team is aware of the situation and can collaborate on a new plan of care, such as exploring alternative treatments or seeking a consultation with another member of the team. This process respects the patient's right to refuse while ensuring their safety remains a priority.
How do you ensure accurate and timely documentation in an emergency situation?
In an emergency situation, My priority is always the patient's immediate safety and stabilization. However, I recognize that accurate and timely documentation is just as critical for patient care, legal protection, and effective communication with the rest of the healthcare team. My approach is to follow a systematic, two-phase process that balances urgent care with meticulous record keeping. During the initial moments of the emergency, while actively providing care, I document key interventions as they occur or immediately after. I use mental notes or a brief, handwritten log to capture critical information like the time of an event, vital signs, and the administration of life-saving medications. For example, I might jot down a note, 10:15 a.m. AP 1 mg for, and 10:16 a.m. BP 60/40. This ensures that I have a reliable record of the timeline and my actions. This is also when I would delegate a colleague to document or serve as a timekeeper if the situation allows. Once the patient is stabilized and the immediate threat is passed, I shift my focus to completing a comprehensive narrative. I use my notes to transfer all the information into the official electronic health record or a patient chart. I make sure to include a clear description of the situation, the patient's condition, the interventions performed, their response to treatment, and who was notified and when. This detailed record is essential for the entire care team, including subsequent shifts in other departments, to understand the full scope of the emergency. This dual-phase approach ensures that my documentation is not only precise but also reflects the urgency and complexity of the situation without compromising patient care.